That's okay. Okay, Mr. Chairman, ladies and gentlemen. So, significant mitral regurgitation, as you know, is one of the most common valvular diseases requiring surgical therapy. About 50% of patients do not receive surgical therapy. Why is that? The reasons for that are severe heart failure, reduced LV function, a lot of comorbidities those patients present with, age over 80 years, and in consequence, high perioperative risk. There's a retrospective analysis from the pre-MitraClip era conducted by the Cleveland Clinic, including more than 5,000 patients with severe mitral regurgitation, mostly with functional MR. And again, it was confirmed that more than the half of this population remained unoperated. And those patients end up with a high 1-year and 5-year mortality and high hospitalization rates. So what is MitraClip? MitraClip is a percutaneous approach based on a venous puncture and a puncture of the interatrial septum. We introduce a big sheath, a steerable sheath called guide catheter into the left atrium and advance then delivery catheter, the so-called MitraClip delivery catheter, through this guide catheter into the left atrium, open the clip, introduce that clip into the left ventricle, grasp the leaflets, close the leaflets, and release the clip. So the last version of this device is the MitraClip NT we are currently using. That has some technical modifications and improvements compared to its predecessor. But the most important thing is to decide what patients we let undergo MitraClip. So indications are as follows: symptomatic mitral regurgitation grade 3. Indication for MitraClip therapy needs analysis of the perioperative risk. The patient needs to be rejected by the surgeon. That is an important difference to transcatheter aortic valve replacement, where we have also patients on moderate risk which can undergo this therapy. Life expectancy must exceed 1 year. The quality of life must be reduced to near class 3, and there must be some improvement expected. Technical feasibility must be given, and we need some morphological prerequisites. So just some types of MR are approachable with MitraClip, some others are not. So types 1, 2, 3B, according to Carpentier classification, are approachable. No rheumatic MR, no endocarditis. So type 1 MR is usually addressed with 1 clip in the middle. Type 2 prolapse, therefore we need, in most cases, we need 2 clips next to each other. And in type 3B, we have mostly a clip in the A3, P3 area. What does the guidelines say? So the American guidelines just recommend MitraClip therapy in degenerative mitral regurgitation, not in functional one. The European guidelines have a recommendation class 2B as the American ones for primary MR, but in addition also for secondary, so for functional MR. So the European guidelines are the only ones recommending MitraClip in functional MR as well. So there are some technical and morphological requirements. There is sufficient leaflet length needed for coaptation. Mitral valve opening area should exceed 4 square centimeters. The defect caused by the flail in case of degenerative mitral regurgitation must not be too big, and calcium should be low. There shouldn't be much calcium at the leaflets to allow grasping of the leaflets. How to approach it? It's a transvenous femoral approach. General anesthesia is strongly recommended. There are some centers, in particular in Germany, doing this without general anesthesia. I would not recommend this. primarily guided by 2D and 3D TEE, and secondarily guided by fluoroscopy. There's no angiography needed, so it's completely free of any contrast application. And that is why this approach is very much kidney protecting and very optimal for multimorbid subjects. So pre-procedural TE, 3D and 2D assessment is recommended. This is degenerative MR, P2 prolapse, type 2 mitral regurgitation according to Carpentier classification. And this is functional MR type 3B. You can nicely discern here the restricted part in that area. '3D echo should provide with a mitral valve end-phase view. So this is again the view from the left atrial onto the mitral valve with the anterior mitral leaflet on the top and the posterior mitral leaflet at the bottom. Regurgitant orifice can be measured, localized, the prolapse can be nicely detected, and color Doppler gives you an idea where to place the clips. Another prerequisite is the space in the left atrium to navigate the catheter system. There's a certain distance needed between the puncture site and the mitral valve annulus. 3.5 to 4 centimeter space is needed to safely maneuver the bulky catheter devices through the left atrium down to the mitral valve. So that needs to be measured beforehand in the 4-chamber view, as it is shown here. So that is how it works. TE-guided puncture of the interatrial septum in different cut planes. The needle is placed. The tenting, so-called tenting phenomenon, is observed, and the puncture safely performed into the left atrium. Then the access sheath is introduced. As you can see here, it is pretty bulky, so that is why general anesthesia is required. There must be any movement of the patient needs to be avoided to prevent any perforation of the left atrial wall. Next step is the introduction of the delivery catheter with the clip on the top. The clip is advanced into the left ventricle, opened, pulled back, the leaflets grasped, and the clip closed. Then we take a look with color Doppler on the result and decide whether the next clip, a second clip, is needed or not. So here we have one clip in position. There's a residual MR of at least grade 1. So in those cases, our experience tells us that on the long run, that may worsen, and that is why we want to optimize those results with the second clip, in particular in type 2 mitral regurgitation. And after the second clip, there's just a trace remaining after positioning or deployment of the second clip. So this is a very old male patient with degenerative mitral regurgitation, low ejection fraction, coronary artery disease, a lot of comorbidities. As you can see here, this is a flail leaflet. The flail gap is pretty big, 11 millimeters, and the flail width is 17 millimeters. So that is approachable, but it's not optimal. It requires a certain experience to be successful in at least 2 clips. This is another example, very old female, again, low ejection fraction, near class 4 renal failure, but here the TE shows us it's an endocarditis, it's a vegetation, plus perforation of the posterior mitral leaflet. That is not approachable. This is not a case for MitraClip therapy. Let's take a look at the data. The Everest 2 trial, the first and most best known trial in terms of MitraClip validation, told us some years ago that freedom, in terms of freedom of death, surgery and mitral regurgitation of grade 3, MitraClip is superior to surgery. In terms of efficacy, surgery is superior to MitraClip, but at least 10% of surgical patients remain in class 3 after, or remained in class 3 after surgical mitral valve repair in that cohort. So the comparison of adverse events showed some benefit for the MitraClip therapy. However, there's some bias here because transfusions were counted as adverse events. The 5-year survival is similar between MitraClip therapy and surgical repair. There are some other trials or registries. There are no randomized trials yet in terms of MitraClip therapy or validating MitraClip therapy. That is a huge weak point of that therapy. The Access-EU trial is one of the most known or best known non-randomized registries, showing that about 75% of patients improved clinically after MitraClip therapy. They improved in terms of reduction of mitral regurgitation, severity in terms of 6-minute walk test and exercise capacity, and in terms of neurofunctional class. The TRAMI registry, another registry focused on patients with functional mitral regurgitation, and showed that, again, that 62% of patients improved clinically. Another non-randomized trial published by Swans et al. Showed that MitraClip is superior to conservative treatment in high-risk degenerative and functional mitral regurgitation. The PERMIT care focused on CRT non-responders and showed that the left ventricular diameters, the left ventricular volumes decreased, and the left ventricular ejection fraction increased after MitraClip therapy in those CRT non-responders. So it was nicely demonstrated that MitraClip is an option in patients who are CRT non-responders. As you know, the lack of mitral annuloplasty is a weak point of MitraClip therapy, and that's why a lot of other approaches have been proposed in the last years. One of the most promising ones is the percutaneous annuloplasty, the cardioband technique that requires puncture of the interatrial septum. It is a transvenous approach as MitraClip therapy, and from that approach, the cardioband is deployed around the mitral valve and then pulled together. Then the ring is then pulled together, resulting in a better coaptation in functional mitral regurgitation. It can be done separately. It can also be done complementary to MitraClip therapy, and is, in my eyes, the most promising approach for the next future in the field of percutaneous mitral valve repair. So let me summarize that shortly. MitraClip is feasible, safe, and well tolerable. These are the advantages. It is less effective compared to surgery. This is a weak point. The indication is to be set restrainedly. Heart team approach is, of course, mandatory to make a decision here. There are new approaches upcoming, and adequate patient selection and echo guidance is necessary, is required, is key for success. Thank you very much.